Imagine a healthy 42-year-old woman goes to her doctor
Okay.
and she's complaining of sudden, like, crippling anxiety, maybe some insomnia, a racing heart.
There's a shockingly high chance she will walk out of that office with a prescription for antidepressants
Yeah,
or sleeping pills.
right. Because the doctor looks at her, sees she's, too young for that classic textbook image of menopause, asks if she's having hot flushes.
Which she isn't.
Exactly, she isn't.
Yeah.
So they just decide it's a primary mood disorder. But according to the newest medical guidelines, I mean, her brain isn't broken at all. Her reproductive system is just initiating this decade-long shutdown, and she is experiencing the very first entirely silent signs.
Yeah, millions of women are being treated for the wrong conditions simply because the medical establishment, and honestly society at large, just completely misunderstands how this transition actually begins. We've been conditioned to look for the fire when we really should be looking for the smoke.
I love that analogy. Welcome to today's deep dive, everyone. We are taking on a massive area of confusion that affects half the population, and we're exploring a very specific, crucial question for you today. What are the absolute first signs that menopause is starting?
And emphasizing the word first is vital here. We are not looking at the late-stage symptoms. We are decoding the earliest biological alarms.
Yeah. To do this, we've brought together a really comprehensive stack of sources. We're pulling directly from official medical frameworks, specifically the NICE guidelines from the UK.
Right, the National Institute for Health and Care Excellence.
Exactly. We also have recommendations from the British Menopause Society, clinical insights from the Society of Obstetricians and Gynecologists of Canada, plus these great deep dive reports from Myova and Goldman Labs.
It's so important because the medical community is finally starting to recognize just how complex this specific window of time is. Relying on this wide lens of sources allows us to separate the outdated myths from the actual endocrinology.
For sure. So, our mission for you today is to shortcut your path to being well informed. We want to help you identify these early surprising signs of the transition, what is medically known as perimenopause, long before the classic symptoms appear, so you can be your own best advocate. Okay, let's unpack this.
Sounds good.
Before we can spot the first signs on the outside, we have to look under the hood, right? We need to understand the mechanical shifts happening on the inside. Because the common narrative is that reproductive hormones just, I don't know, slowly fade away as a woman ages.
Like a dimmer switch.
Yes, like a dimmer switch gently turning down over a decade.
Yeah, but the dimmer switch analogy is entirely wrong.
Really?
The reality is incredibly chaotic. And to understand the chaos, we have to clarify the terminology first. Because the word menopause itself is widely misused in everyday conversation.
How so?
Well, menopause is not a phase, is not a prolonged transition. Menopause is just a single day.
Wait, a single day?
Just one day. It is the exact 12-month mark after a woman's final menstrual period. That's it. In the UK, the average age for that specific day is 51.
Wow. Okay, so it's literally just a date on the calendar. Once you hit that 12-month mark, you transition instantly into being postmenopausal.
Exactly. The entire prolonged phase leading up to that day, the period where all the profound physiological changes actually happen, that is perimenopause.
Right.
And that transition can start in a woman's late 30s or early 40s.
Mhm.
It typically lasts anywhere from 4 to 10 years.
10 years. I mean, that is a massive chunk of life to be in a transitional, fluctuating state.
It really is. And during those 4 to 10 years, hormones do not experience a steady linear decline. They are on a wild roller coaster.
Okay, so what's actually happening then?
Here is the mechanism. As a woman ages, the ovaries become less responsive. The follicles, which contain the eggs, are depleting. The brain senses this sluggishness, so the pituitary gland pumps out more and more of a hormone called follicle-stimulating hormone, or FSH.
Got it.
The brain is essentially yelling at the ovaries to get their attention, to force them to work.
It's like a car with a faulty transmission. Like, you step on the gas, the engine just revs and revs at maximum RPMs, but the gears aren't catching.
Yes.
And then suddenly it just slams into gear and jolts forward.
That sudden jolt is exactly what happens with estrogen. Because the brain is yelling so loudly with this surge of FSH, the ovaries sometimes overreact.
Oh, interesting.
This means that during early perimenopause, estrogen levels don't just drop. They can actually spike significantly higher than normal before they eventually plummet. The environment is entirely erratic.
Wait, stop. If estrogen is spiking so high and surging in this early phase, why is the universal narrative that menopause is all about low estrogen? I mean, that doesn't make sense.
What's fascinating here is that the mainstream narrative focuses entirely on the end of the line. It completely ignores the decade-long journey to get there.
No, I see.
The earliest symptoms aren't driven by lack of estrogen. They are driven by the unpredictability of it. The human body relies on homeostasis, right? It thrives on a steady rhythm.
Yeah, it likes balance.
Exactly. When estrogen is surging and plunging erratically, the body's systems lose their anchor. Furthermore, estrogen isn't even the first hormone to drop. The Myova guide highlights this brilliantly. The very first hormone to fall off the cliff is actually progesterone.
Okay, so progesterone exits first, while estrogen is still riding the roller coaster. Why does progesterone disappear?
Well, progesterone is primarily produced by the corpus luteum, which is the structure left over after an egg is released during ovulation.
Right.
As a woman enters early perimenopause, ovulation becomes inconsistent. Sometimes an egg is released, sometimes the cycle passes without one.
Oh, and those are called anovulatory cycles, right?
Exactly. When you don't ovulate, you don't produce that cycle's progesterone.
Which brings us to the actual first signs. Because progesterone is the first hormone to drop, the absolute first symptoms of perimenopause are usually neurological and psychological.
Yes, the alarms go off in the brain long before they go off in the body's thermostat.
That is wild.
It is. Progesterone is the raw material your brain uses to manufacture a highly specific neurosteroid called allopregnanolone.
Let's slow down and unpack that because it feels like the key to this whole misdiagnosis issue we started with. What does allopregnanolone actually do in the brain?
It basically acts as a natural sedative. This neurosteroid binds to GABA receptors in the brain.
Okay.
And GABA is an inhibitory neurotransmitter. You can think of it as the brain's internal braking system or like a heavy, calming, weighted blanket.
A weighted blanket. I like that.
Yeah, it promotes deep sleep, it reduces anxiety, and it keeps emotional responses grounded. So when ovulation becomes erratic and progesterone levels crash, the brain loses its steady supply of allopregnanolone,
So the weighted blanket is suddenly pulled away.
leaving the nervous system completely exposed and highly reactive. This biological loss of the GABA buffer leads directly to the earliest symptoms.
Yeah.
Women report feeling tired but wired. They experience sudden, unexplained anxiety that doesn't correlate with their actual life circumstances at all.
And the sleep issues too, right?
Oh, definitely. They have classic 3 a.m. wake-ups where their eyes just snap open, their mind is instantly racing through a to-do list, and their body feels flooded with adrenaline. It makes it impossible to get back to sleep.
But it's not just anxiety and sleep disruption either.
Right.
The shifting estrogen is hitting the brain at the exact same time. The sources note that up to 40 to 60% of women report experiencing brain fog.
Yes.
Like they forget common words mid-sentence, they misplace their keys, they lose their train of thought entirely. How does erratic estrogen cause cognitive blips?
Estrogen has a direct impact on dopamine signaling and cerebral blood flow. It helps neurons communicate efficiently and ensures the brain gets adequate oxygen and glucose.
Oh, so it's metabolic.
Right. When estrogen levels plunge erratically, that metabolic support fluctuates. It is a temporary physiological change in the brain's environment, not a sudden loss of intelligence.
But I imagine it is incredibly distressing for the women experiencing it, which circles right back to your opening point about the doctor's office.
Exactly. A 42-year-old woman goes in with a sudden onset of severe anxiety, insomnia, and cognitive fog. The doctor looks at her age, sees she has a demanding career and maybe kids at home, and just assumes it's stress-induced depression or generalized anxiety.
So they prescribed an SSRI.
Yep. The clinical connection to the endocrine system is completely missed because she doesn't fit the stereotypical demographic for menopause, and she isn't reporting hot flushes.
Right.
She is treated for a primary psychiatric condition when, in reality, she is in the early stages of an endocrine transition.
That is so frustrating. Because that GABA buffer is gone, the brain is in a state of high alert. But does that same lack of progesterone translate down to the physical menstrual cycle?
Oh, absolutely. It alters the physical cycle dramatically.
Yeah.
According to the Goldman Labs report, a primary physical first sign, one that can actually be tracked on a calendar, is a consistent change in cycle length by 7 days or more.
7 days.
And counterintuitively, cycles usually become shorter first, not longer.
So a woman who has been running a reliable 28-day cycle for 2 decades might suddenly start seeing her period arrive every 24, 22 days.
Exactly. The early recruitment of follicles, driven by that loud FSH signal we talked about earlier, speeds up the first half of the cycle.
Ah.
Eventually, as perimenopause progresses into the later stages, the pattern will flip, and the cycles will stretch out to 35 days, or even gaps of 60 days or more.
Here's where it gets really interesting, though. What's striking in the sources is how much the actual bleeding changes.
Yes.
Women can go from having totally manageable, predictable periods to suddenly soaking through a heavy pad every hour. Or they might experience the complete opposite, incredibly light periods with random spotting for days on end.
This goes back to the mechanics of unopposed estrogen. Estrogen is the hormone responsible for proliferating or building up the lining of the uterus. Progesterone is the hormone that stabilizes that lining and dictates when it should shed cleanly. So without the regular progesterone signal from ovulation, estrogen just keeps building that uterine lining thicker and thicker, unopposed.
Oh, I see. It's like a musical orchestra that has lost its conductor.
That's a great way to look at it.
Yeah, the strings, the estrogen and the brass, the progesterone, they're just playing at totally different tempos. So when the body finally decides to shed that thickened lining, the volume is massive.
Resulting in shockingly heavy, prolonged bleeding. Conversely, if estrogen levels happen to crash early in that specific cycle, the lining remains very thin, which results in very light bleeding or just random spotting throughout the month.
It's all over the place.
It is a structural instability caused by the missing hormonal counterweight.
Which brings up a crucial point for anyone listening, especially regarding family planning. Despite the skipped months, the bizarre cycle lengths, and the heavy bleeding, fertility has not ended.
No, not at all. Pregnancy is absolutely still possible until a woman has gone 12 full consecutive months without a single drop of menstrual bleeding.
Wow.
The erratic nature of ovulation during perimenopause means an egg can be released at highly unpredictable times. Assuming the fertile window is closed simply because cycles are irregular is a biological misunderstanding, and it leads to a significant number of surprise pregnancies in women in their mid to late 40s.
I bet. Okay, so the brain is sounding alarms with anxiety and wakefulness. The reproductive cycle is shifting its timeline and volume. But this high alert state doesn't just stay isolated to mood and menstruation.
No, it travels straight into the cardiovascular system.
This is where we see physical alarms that most people never associate with menopause. Symptoms that frequently send women rushing to the emergency room.
Right, the heartbeat awareness. The Biologica source notes that up to 42% of women in perimenopause experience this cardiovascular symptom.
Almost half.
Yeah. It presents as a sudden, forceful thud in the chest, a racing heart, or a terrifying takeoff sensation that often happens right as the body is trying to drift off to sleep.
But how does a reproductive hormone fluctuation cause the heart to suddenly start racing?
Well, estrogen acts as a physiological brake on the sympathetic nervous system, your fight-or-flight response.
Oh.
It modulates how the body responds to adrenaline and cortisol. When estrogen levels plunge rapidly or fluctuate wildly, that brake is removed.
So the central nervous system loses its shock absorbers.
Exactly. Without that reliable estrogen brake, even a minor everyday stressor, like a sudden noise or a stressful thought, can trigger an unchecked release of adrenaline.
That sounds awful.
It feels like a fire alarm going off in your chest, even if you're just sitting quietly reading a book. Furthermore, fluctuating estrogen subtly alters the heart's actual electrical pathways, which makes ectopic beats or skipped beats much more common during this phase.
But wait, if someone is lying in bed and their heart suddenly takes off at 130 beats a minute, that is objectively terrifying. How does a person know it's a first sign of perimenopause and not an actual heart attack?
Yeah, making that distinction is paramount. While perimenopausal palpitations are usually brief and structurally harmless, the sources provide clear red flags.
What are they?
If you experience chest pain or heavy pressure that spreads to your jaw, your left arm, or your back, if you experience fainting, severe shortness of breath, or sudden dizziness, or if your heart rate stays elevated above 140 beats per minute for more than 10 minutes, you must treat it as a medical emergency and call an ambulance.
Right. Better safe than sorry.
Absolutely. However, if it's a brief, fluttering episode that passes within a few minutes, particularly if it coincides with a shifting menstrual cycle or new sleep disruptions, the underlying driver is very often hormonal.
Okay, that's really good to know. And the erratic hormone environment is also triggering other systems, right? The sources highlight the worsening of migraines as a major early indicator.
Oh yes, for women who have a history of migraines, early perimenopause can be an incredibly difficult window. Clinicians often refer to this period as puberty in reverse.
Puberty in reverse, wow.
Migraines are highly sensitive to hormonal fluctuations. The erratic, steep drops in estrogen act as a profound neurological trigger.
Right.
This lowers the overall migraine threshold, meaning stimuli that previously wouldn't cause a headache, like a glass of wine or a slightly stressful day, suddenly result in a multi-day migraine.
And I imagine that's compounded by the fact that these patients are often severely sleep deprived from the night sweats or anxiety.
Precisely, it's a vicious cycle.
And then there's the impact on the skeleton and connective tissues. Some clinicians are now using the term musculoskeletal syndrome of menopause.
Yes.
Over 70% of women report new joint pain, stiffness, or what feels like a frozen shoulder during this time. Why does that happen?
Because estrogen plays a direct role in regulating fluid metabolism within connective tissues. It dictates how much water your cartilage and ligaments hold. So when estrogen levels decline, the tissues literally lose their hydration,
The biological lubrication in the joints just dries up.
creating sudden friction and stiffness. It feels like a rapid onset of arthritis where getting out of bed in the morning becomes physically painful. But the root cause is entirely endocrine.
Okay, let's look at the sheer scope of this landscape. We have sudden anxiety, 3 a.m. wake-ups, cognitive fog, cycle shifting by 7 days, unopposed heavy bleeding, racing hearts, intensified migraines, and dried-out aching joints.
It's a lot.
It is a lot. With such disparate systemic symptoms, how do you actually prove to a doctor that perimenopause is the root cause? The answer requires dismantling a massive, entrenched medical myth.
If we connect this to the bigger picture, the modern medical system is built on quantifiable data. Doctors rely heavily on laboratory results to confirm a diagnosis.
Sure.
But perimenopause is the glaring exception to that rule, leading to what we can call the blood test myth.
The idea that a simple hormone panel will give you a definitive yes or no.
Exactly. Doctors frequently order a blood test to check FSH, follicle-stimulating hormone. But we established earlier that in early perimenopause, hormones are on a chaotic daily roller coaster.
Meaning you could go into the clinic on a Tuesday morning, have your blood drawn, and the test comes back normal. Because on that specific day, your brain and your ovaries temporarily aligned.
Right. You could have a pristine, normal blood panel on a Tuesday while experiencing debilitating, life-altering symptoms on Monday and Wednesday.
That's crazy.
A single hormone snapshot is highly unreliable for diagnosing early perimenopause because it cannot capture the fluctuation, which is the actual source of the symptoms.
This is deeply counterintuitive for patients, though. We are so conditioned to defer to the lab results.
We are.
If a doctor looks at the paper and says your hormones are normal, the patient assumes the anxiety, the brain fog, and the exhaustion must be a personal failing. But the official guidelines completely reject this reliance on blood work.
They do. The NICE guidelines, which are the gold standard for medical practice in the UK, explicitly state that in otherwise healthy women over the age of 45 who present with menopausal symptoms, doctors should diagnose perimenopause clinically.
Clinically, meaning the diagnosis is based on the patient's narrative and history.
Based purely on symptom history, vasomotor symptoms, irregular periods, sudden mood changes, joint pain. The guidelines specifically instruct practitioners to make this diagnosis without requiring laboratory blood tests to confirm it.
So the official medical framework actually empowers you, the patient, to tell your doctor, my symptom journal is the proof, not the blood test.
Yes. Meticulously tracking your symptoms is the single most powerful tool for self-advocacy. Documenting the 24-day cycles, logging the 3 a.m. wake-ups, and noting the exact days the joint pain spikes that tells the story of the hormonal roller coaster far more accurately than a vial of blood drawn on a random Tuesday.
We started this deep dive looking for the absolute first signs of menopause, seeking to clear up the muddy waters of misdiagnosis. And what the sources reveal is a complete paradigm shift.
It really is.
The first signs are rarely the textbook hot flushes. They are a complex, interconnected web of neurological, cardiovascular, and reproductive shifts. It's the cycle changing by 7 days.
Yeah.
It's the sudden, unexplainable anxiety from a drop in the brain's GABA buffer. It's the racing heart when the estrogen brakes are abruptly pulled off the adrenaline system. Understanding the mechanics behind these changes equips you to connect the dots early.
Exactly.
It means you don't have to suffer in silence, you don't have to accept a misdiagnosis of a mood disorder, and you can walk into a clinic equipped with the right data to advocate for your own care.
And, connecting these dots early goes far beyond just managing daily comfort or securing a better night's sleep. There is a striking revelation from the Swanbone study that highlights the hidden long-term stakes of this transition.
Oh, what did they find?
The study revealed that by the time a woman reaches actual menopause, that single day marking 12 months without a period, she might already be classified as a fast bone loser.
Wait, really?
Yes. The research demonstrates that significant, irreversible bone density loss actually begins about 2 years before the final menstrual period.
Wow.
So identifying these absolute first signs is the critical window for intervention. It is the limited time frame where you can actively save your skeleton for the rest of your life, something to think about the next time your cycle arrives a week early.